about fibrous dysplasia, McCune Albright syndrome. Thanks for being with us, Michael. And Michael is on our faculty for this, I forgot to add, and we're very grateful.
Thank you, Laura, and you're welcome for being on the faculty. I'll quickly dispose of my disclosures, I think. Slides to work here. For some reason, there we go. There's my disclosures. And here is a definition of fibrous dysplasia McCune Albright syndrome. It's a little bit wordy, but I think that this is important. This is along the lines of the excellent talk that we had at the ASBMR by Les Biesecker about the definition and naming of these disorders that acquired eponyms before the molecular understanding of these. So fibrous dysplasia McCune Albright syndrome is a constellation of findings across the spectrum of severity. It's caused by gain-of-function mutations in G-alpha-S. It involves the skeleton with or without extraskeletal manifestations. The skeletal disease can involve a single bone, monostotic, multiple, polyostotic, or rarely panostotic. The extraskeletal manifestations can include any combination of catheolae macules, hyperfunctioning endocrinopathies, FGF23-mediated rickets, osteomalacia, neoplasms, mostly benign, and others. Fibrous dysplasia can involve any part of the skeleton, the craniofacial, the axial, and the appendicular. And depending where it is, it has different manifestations, radiographically, clinically. It has different complications, deformity, fractures, and pain, and we'll go into these more as we go on. The extraskeletal manifestations, most of which are shown here, can be endocrine hyperthyroidism, Cushing's disease, growth hormone excess, precocious puberty, rickets, and others, as I've shown you. It's a fascinating disease with an incredibly wide spectrum, as is shown here with these two patients with the same disease, McCune Albright syndrome, but in one patient with growth hormone excess and gigantism, and another patient with precocious puberty and short stature. The molecular etiology of the disease is activating gain-of-function mutations in G-alpha-S, which is coded for by the gene GNAS. It involves loss of the GTPase activity of the alpha subunit such that there's prolonged and ligand-independent signaling through any of the cells that have receptors that involve G-alpha-S as the predominant part of their signaling. And so depending on the cell or the tissue, it determines the manifestation. So in bone, fibrous dysplasia, skin, catheolae spots, and precocious puberty, and the others shown over here as well. FDMES is an example of somatic mosaicism, as shown here in these bone scans. Patients can have a combination of, as we said, craniofacial and axial skeletal disease. It can be mild, it can be almost just an incidental finding found during a CT for some reason, or it can be quite dramatic and life-changing and even life-threatening. These the skin macule shown here demonstrates that these skin findings follow the developmental lines of Blaschko, which indicate that this is a developmental disorder. That again, shown here in this testicular ultrasound, that there can be patchy involvement of one side and not the other. There have been no cases of vertical transmission, and it's been presumed then that germline mutations would be lethal and mutations survive through mosaicism. The etiology of fibrous dysplasia developmentally is shown here in this cartoon. We know that, for example, if a patient shown over here on the right has a phenotype that involves tissues derived from ectoderm, mesoderm, and endoderm, so skin, thyroid, testicles, bone, then the mutation has to have occurred before gastrulation at the inner cell mass stage. Mutation occurs by chance. There's no known environmental or genetic causes that we know of. The mutated progeny proliferate in the gastrula phase and then establish the disease during the embryo. So therefore, the map of the affected tissues is charted quite early in utero, and this has significant implications for understanding the clinical phenotype of the disease. And one of the implications is shown here. The approximate onset and offset of affected tissues is shown in this slide. So fibrous dysplasia generally manifests clinically very early in life. The cafe au lait spots are the manifestation that occurs the earliest and are usually present at birth or shortly thereafter. Precocious puberty can occur anytime between early childhood and maybe up to 5 years or so. Thyroid disease shown here, phosphate wasting, etc. These aren't hard and fast rules, but these are general applications that can be used to understand the disease. Really only a couple of these wane with time, and that is phosphate wasting can go away with time. Cushing's disease only occurs in the neonatal period, and by definition, precocious puberty is in childhood. So the implications of this clinically for patients and family is that if you conduct complete staging quite early in life, 5 years or so, it allows for determination of the affected tissues and the unaffected tissues. Most unaffected tissues after a complete staging do not need to be reassessed later in life. Moving into a discussion about fibrous dysplasia, the skeletal disease part of McCune Albright syndrome. It has to do with mutations that occur in skeletal stem cells. So we know that skeletal stem cells give rise to cells in the bone marrow that are called bone marrow stromal cells, and these can give rise to osteoblasts, osteocytes, chondrocytes, adipocytes, and the hematopoietic supportive cells. What we think happens in fibrous dysplasia is shown here, that one of these skeletal stem cells, or a skeletal stem cell, harbors a mutation, and that cell carrying the mutation seems to have a proliferative advantage over the rest of the cells. So there are some wild-type cells admixed with the mutated cells, but the mutated cells proliferate much more rapidly, and they seem to co-opt the function of the wild-type cells as well, so that they behave as if they're mutated cells. In lesions of fibrous dysplasia, there's loss of hematopoietic support, loss of adipocytes. Really, there aren't chondrocytes. And what occurs is really a sick little osteoblast that gives rise to a sick little osteocyte. And this is shown better in this slide here, which really demonstrates the broad spectrum of manifestations in fibrous dysplasia. So fibrous dysplasia is one of what's known as fibroosseous diseases. So there's a fibrous component as shown in this area of the slide, and there's an osseous component as shown here. So in fact, there's really a lot of bone in fibrous dysplasia. You can see all of the green and blue in this lesion here represents bone. But there's replacement of the normal bone marrow with this fibrous tissue that's shown here. In fact, there's massive de novo bone formation throughout here, but it's woven, poorly mineralized bone as shown here in the slide here. It's highly vascular. You can see this blood vessel here with red cells coursing through it and depositing red cells in this venous lake here, very vascular tissue, a lot of bleeding during surgery. It's an abnormal matrix, as shown here by these Sharpey's fibers, which shouldn't really be in this part of the bone. There's very active bone turnover. Bone turnover markers are extremely elevated in fibrous dysplasia. And as I said, they're making a lot of bone, but it's bone that's disconnected from trabeculae. It's woven, it's weak. It's just not healthy bone. An interesting feature in fibrous dysplasia, which is emerging as having very important implications, is it's a prominent component of osteoclasts in fibrous dysplasia shown here. Sometimes they're huge, and sometimes there's a lot of them, and we'll talk about that more in just a little bit. So again, with the age of onset and the phenotype in fibrous dysplasia, the implications are shown here. This is a study that we did some years ago where we looked at what age is 100% of fibrous dysplasia acquired. And these are serial bone scans on a relatively large number of patients. And what happens is shown here, such that clinically, while about half of the disease is present at the age of 5, in fact, about 95% of that disease, which is clinically significant, is present very early in life. So again, early complete staging can give you a pretty clear indication of the severity of the disease that a patient has and what to expect later in life. Other implications are shown here. There does seem to be a sort of waning or a sort of burnout of active disease in patients with fibrous dysplasia. And this is shown in this slide here, which was recently published by Pablo Lorenzano, where he showed that there is very clearly a decline in bone turnover markers with age. And this was a depiction here by Pam Roby and Sergei Kuznetsov, where in older patients with fibrous dysplasias, who radiographically, for all the world, it looks like fibrous dysplasia, but they've had this for a lot of years, and you do biopsies, you can begin to see the recurrence of a relatively normal bone marrow and relatively normal bone, osteomalacia here shown here, but also even yellow marrow. So there does seem to be some sort of burnout, or at least at the microscopic level, healing of the bone with time. Moving on to the craniofacial sequelae of fibrous dysplasia. It covers a large spectrum, so it can be nasal obstruction, which is largely mostly a nuisance. There can be malocclusion. When it's severe, it can cause difficulties with mastication. There are, in some patients, loss of hearing by overgrowth of bone on the otic canal. There's asymmetry, which is largely effects are cosmetic. And occasionally there can be narrowing of the optic canal with some vision loss. The management of the skull-based fibrous dysplasia is shown here in this slide with a series of papers that we've published over the year. These patients can get massive macrocephaly with fibrous dysplasia, especially those with growth hormone excess. And there can be narrowing and even obstruction or obliteration of the optic canal. What we found early on, though, was that prophylactic optic nerve decompression, which at the time had been the standard of care, really is not indicated. Most patients will not develop any serious significant sequelae of function due to skull-based disease. Much preferred is watchful waiting, and is superior to surgery in this meta-analysis that was done. We were able to show pretty clearly that growth hormone excess is a risk factor for vision loss, for macrocephaly, hearing loss, and other things as well, which I'll get to. What we were also able to show is that if you're able to diagnose growth hormone excess early and initiate treatment, you can prevent some of the sequelae of growth hormone excess effects on patients with skull-based fibrous dysplasia. As far as other skeletal surgical complications and surgery related to craniofacial fibrous dysplasia, this is a study published a few years ago by my colleague Alison Boyce, where we reviewed all the patients that have been seen in the NH cohort and looked at all those who had craniofacial surgery. The indication for surgeries are shown here. Otic canal obstruction was relatively uncommon, malocclusion, nasal airway obstruction, and facial asymmetry. And in looking back at these patients, over 103 procedures, what was clear is that overgrowth is really quite common. So if patients are going to go for surgery, you really need to manage their expectations. If they're going to have a craniofacial surgery, it's quite possible, even likely, that it's not going to be the last surgery that they'll need. Overall, the regrowth was about 68%. And those patients who have what are sometimes called debulking procedures, where these are sort of shaving down of the bone disease, these quite regularly grow back. If they did full sort of en-bloc resections with reconstructions, these are less likely to regrow. But growth hormone excess, again, complicated the disease and contributed to about the fact that 88% of those patients would have regrowth. So management of the craniofacial fibrous dysplasia, I think, is very, very important. The very first thing that you have to do is make sure that's an experienced craniofacial team. It needs to be a team, and it needs to be doctors that have some experience with operating on this. Indications are quite personalized. There's functional impairment, deformity, cosmesis. Often we recommend only if it's severe. We don't recommend prophylactic procedures in terms of optic canal decompression. And generally, because of the regrowth, debulking should be avoided. Prevailing questions that exist are, what about the indications and timing for surgery, identifying predictors of regrowth, besides and beyond growth hormone excess, for example, and the optimal materials and techniques to be used on these patients. So moving on to axial fibrous dysplasia. This is a very important slide. So the vertebrae of the spine are commonly involved with fibrous dysplasia, and you can see this is a very dramatic case here. This patient had involvement of practically every vertebra. Surprisingly, she had no neurologic sequelae of this. She was pain-free and there was no nerve compression. This is actually quite common. But the big thing to worry about, think about in patients with fibrous dysplasia who have disease in the vertebrae, is that they quite commonly develop scoliosis. The scoliosis can be progressive and it can even be lethal, as is shown here in this autopsy that was performed by this patient who died from complications of scoliosis. And we've seen a number of patients where this has been the case, and it's really quite disturbing because, in fact, it seems to be the case, and much to the surprise of us and the surgeons that do the operations, is that surgery for scoliosis seems to be very effective. We've had a lot of patients who've had rods placed for scoliosis, and we've only had one patient who's ever required a second operation. So there's been durability of up to 30 years with scoliosis surgery. So very important to think about, suspect, and check for scoliosis. If it's there, monitor it and get it before it gets too bad, because it can lead to demise, and it's quite well managed with typical surgical rodding techniques. Okay, how about the appendicular skeleton? Some of the issues shown here: the classic shepherd's crook deformity with the bowing of the proximal femur. This, of course, reflects the fragility and the weakness of the bone, leads to fragility fractures, windswept deformity, and pain is quite common also. So the surgical management of this is actually a whole talk in itself, and I'll just distill this down to a few points. The indications for surgery are weight-bearing pain that's not controlled otherwise, deformity that impairs gait. What is generally we've moved beyond and moved away from is curettage and grafting. This was recommended early in the treatment of fibrous dysplasia. Several important centers, including those at the DuPont Institute in Leiden, have shown very clearly that curettage and grafting is not the best treatment, especially for young patients with fibrous dysplasia. More commonly and better, the use of intramedullary rods. And when to operate, some people say, is that when the neck shaft angle, which is shown here and depicted here, a normal one of which is about 135 degrees in adult, that when this slips below 110 degrees, that's the time where you need to do a prophylactic rodding of that femur to maintain function and to prevent fractures. Okay, what about the effect of the extraskeletal manifestations, the endoprinopathies? Hypophosphatemia can contribute to earlier, more often, and more frequent fractures, as is shown here in this slide. Hyperthyroidism and hypophosphatemia have been shown to be independent risk factors for the development and progression of scoliosis. Hyperthyroidism and hypophosphatemia can contribute to basilar invagination, which can be a very disturbing finding in patients with fibrous dysplasia, very difficult to treat. So again, early diagnosis and treatment of hypophosphatemia probably can help to prevent this from occurring. And finally, growth hormone excess is a risk factor for vision loss, as we said, and hearing loss as well. Moving on to the very important topic for most of the patients with fibrous dysplasia, probably the most difficult to manage, is pain. And this was a paper that we did a number of years ago, where we showed that the general prevalence in the cohort that we see here, which is typically a more severely affected cohort, that most of the patients, 81% of them, had pain, and the children had less. It's not uncommon for children not to have pain, but about the age between 15 and 20 years old, they begin to develop pain. This group, the average pain was relatively low, although for some patients it's quite disabling and severe. And interesting findings were this: we found that a greater proportion of the children compared to the adults had no treatment for their pain. So that's not good. That's a disturbing finding. We did find that the various treatments that were used in the group of patients at that time had some degree of efficacy. NSAIDs actually worked pretty well. The bisphosphonates for patients with pain seemed to work the best. And alternative therapies actually could be quite helpful as well. At this time, not many of the kids were receiving these things like acupuncture and massage and that sort of thing, but they work quite well for patients, and it's an important adjuvant to think about. Important findings are pain increases with age. It's often untreated in children. And bisphosphonates are generally effective in one of the first-line therapies for pain after you've exhausted more conservative measures such as NSAIDs, etc. Okay, this is a very interesting finding in fibrous dysplasia. It was somewhat surprising to us when we did this. And you can see from this slide that's shown, this graph, that there's really no correlation whatsoever between the amount of fibrous dysplasia that patients have and the average pain that they have. So, for example, here are some patients out here with really severe pain and hardly any fibrous dysplasia. Then at the same time, there's patients with a lot of fibrous dysplasia and very little pain. So there's something going on with the pain that we really don't have a handle on. But I think we're beginning to crack this nut, and is shown here. This is work that was done by Alison Boyce and Tiana Spencer, who was a student in the lab at the time, in conjunction with Kassim Javed, where they looked at both the Fibrous Dysplasia Foundation and the Rudy registry in the UK. And it was actually very surprising that there was tremendous, very high degree of concordance between the reported findings between these two very different groups of patients. And what was very interesting is that a very high percent of the patients, and those patients who seemingly had the worst pain, that the pain was more of a type that would be considered neuropathic. So this is a type of pain that probably isn't going to respond to some of the more conventional therapies that we have. So it raises the question of really, what are the mechanisms of pain in fibrous dysplasia? This neuropathic pain suggests that there's some nervous system component, whether central, peripheral, or both, remains to be seen. What's the etiology of the age-related changes, and what is the optimal treatment? Well, the optimal treatment remains to be determined, and it depends on the patient. And for those patients who have neuropathic pain, some of the medications that target that may be a better first choice. So, one of the big questions about fibrous dysplasia, and one that was offered up early, and we'll probably hear more about this in the question section, is that of bisphosphonates. So one of the earliest and best studies was by Horacio Plotkin when he was with Francis Goriot in Montreal, and they looked at patients with fibrous dysplasia that they treated with relatively high doses of pamidronate along a regimen that mimicked that which is typically used for osteogenesis imperfecta. They did biopsies before and after, and interestingly, they showed no effect of relatively high-dose bisphosphonate treatment on the histology or the histomorphometry of fibrous dysplasia lesions. We conducted the first ever and only double-blind placebo-controlled study of patients with fibrous dysplasia. We used relatively high-dose oral alendronate. 36 patients were treated for 24 months. Oral alendronate had really no significant effect on pain, but it did increase bone mineral density in children. This was a study that we published this year where we looked back at all the patients we had ever seen here. And we looked and did, this was an open label study, patients who received bisphosphonates and didn't receive bisphosphonates were matched for as well as they could be, so they're treated and untreated. And there were a couple of interesting findings. So first of all, the change in bone turnover markers that occur in patients with fibrous dysplasia seem to, over the lifetime, seem to be little affected by bisphosphonates. So you can decrease bisphosphonates, bone turnover markers to varying degrees with bisphosphonates, but you pretty much end up in the same place. They really don't seem to change the natural history of the disease. And this was confirmed in this analysis as well. We showed that bisphosphonates had no effect on the appearance of new lesions in fibrous dysplasia or the growth of lesions in fibrous dysplasia. So bisphosphonates do not seem to be indicated for the purpose of preventing fibrous dysplasia. They seem to have a good effect, especially the high-dose intravenous bisphosphonates on pain, but they don't change the natural history of the disease. So that brings us to one of the newer drugs for the treatment of FD, and that's Denosumab. This was the first patient that we know that was treated with Denosumab. This was published here by Alison Boyce. And this was a little boy with, really very dramatic, incredible fibrous dysplasia. he had this lesion in his leg, which grew rapidly and ultimately resulted in an amputation. This lesion, identified by the arrow, started to take off just like this one over here. And actually it was scheduled to have an amputation of this other leg as well. But prior to doing that, we got permission to perform a compassionate use study with Denosumab in this little boy, and the effects of that are shown here. So the lesion was growing like crazy. He received Denosumab, and the lesion the growth seemed to slow down a lot. Bone turnover markers decreased tremendously, and most importantly, he went from using daily narcotics to being pain-free. There was an unfortunate social situation. This little boy was lost to follow-up, and the Denosumab was stopped very rapidly without any close follow-up. And you can see what happened here. He developed really life-threatening hypercalcemia. This is the blood calcium. It went up to almost 18 milligrams per deciliter. And there was a tremendous rebound in the bone turnover markers. He started out with a CTX of about 2,000, which is incredibly high. While on Denosumab, the CTX returned to the normal range. With abrupt cessation of Denosumab, you can see the rebound that he experienced in his bone turnover markers. And this sort of parallels, but is a magnified version of the rebound effect that can be seen even in patients with osteoporosis. So this is a very concerning finding. We don't have a good handle on this yet. It's something we have to know better. A quick look at what we know about Denosumab and fibrous dysplasia so far. There have been 5 published studies of varying sizes, all open label, various doses. There were no objective measures of pain. Most studies had self-reported decrease in pain. Most studies had disturbances in mineral homeostasis, hypocalcemia, hypophosphatemia, increase in pH. Only one study looked at the discontinuation effect, which I think is very important. That was the one I just discussed with life-threatening hypercalcemia. We have some additional experience in patients treated with fibrous dysplasia. With relatively high doses over long periods of time, patients can develop sort of osteopetrotic changes. And on discontinuation, it's very interesting though, there is some degree of mineralization of the fibrous lesions with treatment of Denosumab. But with discontinuation, there's resorption of that bone which was formed in hypercalcemia. Very interesting recently published report I encourage you to take a look at. It's in the JB Marr. This is a mouse model of fibrous dysplasia from Mario Menucci's group in Rome. And they show that treatment prior to the formation of fibrous dysplastic-like lesions can actually prevent the formation. It started quite early. That the lesions that are there become mineralized with the treatment of Denosumab. But again, on discontinuation, there's resorption of that tissue that had been mineralized, and there was hypercalcemia. So where does this stand? So my recommendations are, first and foremost, further study is needed. If you're going to use these, it should only be used by experts in closely monitored study. You can expect mineralization, homeostasis disturbances with initiation and discontinuation. They probably shouldn't be used in children at this time, and there's probably also a high risk for osteonecrosis of the jaw. So last couple of slides, I just wanted to point out the very nice and important work that's being done by the Fibrous Dysplasia Foundation. They have a very nice registry. There's a registry in the UK out of Oxford called the Rudy Registry as well. And there exists now a consortium, international consortium of investigators involved with fibrous dysplasia. It's really been a pleasure working with this group. I think we're making great progress. These are a couple of papers that we've put together already, and we recently published management guidelines for patients with fibrous dysplasia. This is on the Orphanet. This is open access, and I think they're quite good. One last good resource, I think, for people is this gene reviews that was done by Alison Boyce, Luis Fernandez de Castro, and myself. It's published in Gene Reviews, and we have in that a set of algorithms that really make it quite nice for following and treating patients with fibrous dysplasia. We all like algorithms, and these tell us how to do it. With that, I'll acknowledge all the hard work that's been done by my group here at the NIH to make this work possible. And I think that we have next Michael Stewart questions. Is that right?
Yes, we do. So if anyone has any questions for Dr. Collins,